knee examination. Now we start our talk by the surface marking. The surface marking of the knee is very important. You ask the patient to lie down in a supine position, mark the patella, and then we'll mark the patella tendon, mark the tibial tuberosity, then you mark the joint line on the medial and the lateral side, then you mark the fibula, and the peroneal nerve will be running from posterior to anterior, and now you palpate the bony prominence on the medial side and the lateral side. Also, you should feel about the patella mobility. So you have to see the patellar gliding, and then you can palpate the upper pole of the tibial tuberosity and the lower pole of the patella to see if there is a point tenderness. So it can be, you can have a tenderness over the patella, at the lower pole of the patella, or at the tibial tuberosity, depending on the pathology that you are facing. And then you can see the range of motion of the knee joint like this. The inspection and palpation is usually done by the look, feel and move approach. You start the patient in a standing position, and you should examine the patient in a standing position, in a supine position, in a prone position, and in a sitting position. So in the standing position, you need to look from the front, and you need to see the alignment from the front, whether the patient is in varus, whether the patient is in valgus, and then you start to look, feel and touch, and all the three dimensions. So when you start from the anterior part in a standing position, you have to see the patella, you have to see the alignment of the leg, and you have to see if the patient is walking or standing in a straight position. So this is the front view of the knee, and then you ask the patient to turn on the lateral aspect and see the knee from the side. So this is from the side that you see. So shin and thigh is looked after, and then you have to see the back of your knee. So you have to see if there is any swelling or any other thing that you can see in the popliteal fossa area. So standing examination you have to do in all the three positions, from the front, from the side and from the back. Now you always should see the alignment. So it can be a genu valgum, which is called as a knock knee. It can be a genu varum, which is called as a bow legs. It can be a genu recurvatum. It can be an FFD. It can be, and also look for the gait. The gait can be an antalgic gait or a short limb gait. Now range of motion should be examined. There are some conditions in which the extension is restricted. That is called as an FFD. So that is a bucket handle tear. You can have this in a notch impingement. If you have an anvil osteophyte, you will have this problem. If you have a posterior osteophyte, you will have this problem, and you will also have this problem in a cyclops lesion. You will have a restricted flexion in an arthrofibrosis of the knee, in the suprapatellar fibrosis, in the PCL impingement, and also in the mucoid degeneration kind of a phenomenon. Now the pearls are, you need to examine the contralateral knee always. So always compare the knee which is pathological with the other knee. Always examine the ipsilateral hip, because if this side is hip joint, or pain of the hip joint is many times radiating to the knee joint. So always examine the ipsilateral hip joint, always examine the ipsilateral ankle joint, always feel for the dorsalis pedis and the posterior tibial pulse, always see the motor power and sensation in the lower limbs. Always check the compartment pressure, always check the calf tightness, and always watch for the varicosities. Now there can be some noise which are palpable in the knee. If there is a pop, it is usually heard during the trauma and injury, and that is usually a predictable of a ACL or a meniscal injury. It can be a clicking noise, and it is a single noise which is at a specific part of knee flexion extension cycle, and this is usually suggestive of a meniscal damage or a tear. Now a meniscal clunk is usually a noise which is palpated at a specific part of the knee flexion and extension cycle, and it is usually due to repositioning of the patella in the trochlear groove of the femur, and this is more commonly seen in a post total knee replacement scenario, that is called as a patellar clunk syndrome, and this is more common in a metal back knee joint. A creaking knee is a sound of a creaky door, and usually it is found in an arthritic knee. A cracking or a popping joint is usually spontaneous or during a manipulation, and it is due to the buildup and bursting of gas bubbles within the synovial joint, and this is called as a tribonucleation phenomenon. A snapping knee is a knee joint which is a single noise at a specific part of knee flexion extension cycle, and it is due to a tendon snapping over the bony prominence, usually the biceps femoris tendon or the TFL on the lateral knee, and it is normally physiological, and usually it is an extra articular noise. A fine gritty or a grating sound which is usually a loud noise, it can occur with throughout the knee flexion extension cycle. It comes and goes, and the volume of the sound can change. It is found in asymptomatic and symptomatic people. It has a higher incidence in people with patellofemoral syndrome and osteoarthritis, and there are various theories on the source of noise. But usually, just a noise in the knee, which is fine and gritty, can be asymptomatic. You don't need to worry about it. But if it is accompanied by pain itself, then you need to investigate either for a patellofemoral syndrome or a osteoarthritis. Now, extra-articular pathology must always be evaluated, and in this pathology, the knee range of motion is free. Prepatellar bursitis is also called as a housemaid's knee. Infrapatellar bursitis is called as a clergyman's knee. Now, coming on to the ACL. ACL is usually more common in females. The reasons are multiple. This is because of the physical conditioning, muscular strength and neuromuscular control, which is less in females. The alignment, which is more of a valgus, a broad pelvis and a narrow knee in females. In females, the ligaments are relatively loose, and the effect of estrogen on the ligament properties also make the ACL more prone to injury in female. The mechanism of ACL injury is usually the changing of direction rapidly, stopping suddenly, slowing down while running. If it is landing from a jump incorrectly, if there is a direct contact or collision from a football tackle, then we can do that. Now, coming on to the bundles of the ACL. ACL is two bundle structure. There is an anteromedial bundle and there is a posterolateral bundle. The anteromedial bundle is on the anterior part of the tibial footprint. It restrains the AP forces. There is a proximal and anterior. On the femoral side, the insertion is proximal and anterior, and it is high and deep in the notch when the knee is flexed at 90 degrees. Whereas the posterolateral bundle is on the posterior part of the tibial footprint. It imparts the rotational instability. If it is torn, there will be a rotational instability. And on the femur, it is more distal and posterior aspect. So it is a shallow and low when the knee is flexed at 90 degrees. And usually the posterolateral bundle is more tight on knee extension, whereas anteromedial bundle is more tight on knee flexion. Now, this is how we do an anterior draw test. The patient is placed in a supine position. The knee is bent around 90 degree of flexion. We can either sit or stabilize the ankle, and then we'll use both of our hand to pull the tibia forwards. And any translation which is more than 5 millimeters is suggestive of a anterior door rupture or anterior door or an anterior cruciate ligament tear. It can be done in both in an OPD setup and before starting the surgery. This is not a very good test when we are doing an acute injury, because an acute injury, it is difficult to flex the knee and to do a translation in this phenomenon. So it is not a good test when we are doing a Slocum test. Is a modification of the anterior draw test. The anterior draw test, if it is done in internal rotation of the foot, then it is suggestive of an anterolateral rotator instability, that is an ACL tear along with a PLC injury. And the second variation is an anterior draw in an external rotation of the foot. This is suggestive of an anteromedial rotatory instability, that is an ACL injury along with an MCL and a posterior oblique ligament injury. So, Slocum test is a modification which is suggestive of a combined ACL with a PLC or a POL injury corner. Now, Lachman's test. Lachman's test is usually performed with the patient in a supine position, and what we do is we put the patient in an extension, and when we put the knee joint in extension, and then at about full extension or about 15 degree of flexion, We will ask the patient to lie down in a comfortable position, and then we will test the knee like this in a, so this is a very sensitive test, and this test can even be done in an acute setting, and it has a good sensitivity and specificity. Now pivot shift test is a test for the rotational instability, and it is usually seen in the posterolateral joint. So you keep your hand on the thigh, and then you try to move the knee like this, and there will be a shifting of the pivot, and this is usually suggestive of a rotational instability of the knee joint. Now Lilly's test or the liver test is a recent test which is described by Dr. Alessandro Lilly from Italy. So you put a pillow or something at the proximal tibia, and then what you will do is you will press the distal femur, and usually by pressing that, the leg will go up. If the liver is intact, the leg will go up like this. So this is usually suggestive of a broken connection between the femur and the tibia. So if the ACL is torn, the leg and the foot will not go up. If it is intact, the leg and foot will go up. This is a very good test in an emergency scenario. You can do it in an emergency, but it can be a slight painful thing. So I usually perform in a chronic cases with an ACL tear, and also I perform it in a uh, just before the OT or in the anesthesia. So PCL ligament is a larger and bulkier ligament. It is rarely an isolated injury, and it is more commonly with other injuries. So mechanism of injury is mostly dashboard injury, falls in hyperflexion, direct hyperextension trauma. In case of the PCL, the anterolateral bundle is the main bundle. It represents the 2/3 of the PCL mass, and usually if you have to reconstruct a single bundle PCL, you need to only reconstruct the anterolateral bundle. The PCL has got an intrinsic capability of healing. That is why isolated PCL tear can be managed non-operatively with rehabilitation and bracing. Now this is how we do the posterior draw test. Again, patient is in supine position, the knee is flexed in 90 degrees, and then we push the hand, push the proximal tibia back, and that will lead to the pushing of if there is more than 5 millimeter of posterior translation, the posterior draw test is positive. Now this is called as a Gottfried's sign. We ask the patient to bend the knee 90 degrees, the hip is bent at 90 degrees, and there will be a posterior sag, and if there is a posterior sag, this is called as a posterior sag sign or the Gottfried's sign. Now quadriceps active test is because of the active quadricep contraction, and when there is a posterior sag, when the patient is contracting the quadriceps tendon, the quadriceps tendon is reduced back to the normal position, and it is seen in the PCL tear. Now reverse pivot shift test is seen in with the external rotation, and it is seen in the valgus stress, and usually it is when it is the knee is at 90 degrees, it is in posterior subluxated position, and when it is done in 30 degrees, the knee will subluxate anterior in the normal position. Now dial test. Dial test is classically described in prone position and a 30 degrees of flexion. You can do it in supine position as well. It is defined as the external rotation which is more than 10 degrees as compared to other side, and it is done in two flexion angles. So if it is done at 30 degree flexion angle, it is suggestive of a PLC injury. If it is done in 90 degrees flexion angle and the dial test is positive, it is suggestive of a combined PCL and a PLC injury. Now coming to the valgus and varus test, it is usually suggestive of a MCL and LCL injury. Usually it is done in two angles. You do it in 0 degree extension and you do it in 30 degrees of flexion. If it is done in 30 degrees of flexion, it is suggestive of an isolated MCL and LCL injury, and if it is done in full extension, it is suggestive of a MCL plus injury and a LCL plus injury. So valgus stress test which is positive in 0 degree, that means MCL along with the posterior oblique ligament and a PCL is torn, and if it is for a positive for a varus test, it is positive for a LCL along with a ACL and a anterolateral or a posterolateral ligament tear. Now, patellar mobility, you need to assess the patellar mobility in a supine position in full extension. So when we do, so you divide the patella in 4 quadrants. If and the normal mobilization is 1 to 3 quadrants. If the patella is mobile more than 3 quadrants, it is suggestive of a hypermobile patella and a patella subluxation. If it is less than 1 quadrant, it is suggestive of a stiff patella and restricted patellar mobilization. Now, Q angle is usually measured with there is a line which is drawn from the anterior superior iliac spine to the midpoint of the patella, and a line which is drawn from the midpoint of the patella to the tibial tubercle, and the angle which is formed is called as a Q angle. So this Q angle is usually made from this. The normal value of the Q angle is around 13 to 18 degrees. If it is more than that, it is usually suggestive of a if it is more than 13 to 18 degrees, it is usually suggestive of a abnormal or increased Q angle. Usually the Q angle is 12 degrees for men and 17 degrees for females. Uh, there was a statistically significant increase in Q angle measurement in the standing as compared to a supine position. So ideally you have to measure the Q angle both in a standing position and in the supine position. The Q angle is usually more in extension than in flexion. Now, J test is usually due to the lateral deviation in extension, and it is a test of the dynamic patellar tracking. Now, apprehension test is a test in which we do it in full extension and 20 to 30 degrees of flexion. 1 to 3 quadrant movement is normal, and it is usually suggestive of patellar instability and trochlear dysplasia. If the apprehension test is positive in full extension, it is usually suggestive of a soft tissue instability. If it is positive in more than 20 to 30 degrees of knee flexion, it is suggestive of both a soft tissue damage, that is an MPFL injury, along with a trochlear dysplasia. So here we see that the knee is subluxating significantly laterally. So this is a pre-op picture of a patient in which the MPFL is torn and with minimal trochlear dysplasia, and that patella is mobilizing in this way. Now there can be significant effusion test. So you can see, you can have a glide test, you can just so effusion can be test, you can just do the gliding of the effusion, and then you can tap the patella to see if there is any effusion which is there. If the patella tap is positive, you can have ballotment which is positive, and occasionally you can do a ballotment test or the patellar test, but these tests are positive when the patella the effusion is significantly more. Now, Tinel's test is a test which is done for peroneal nerve pathologies. So as we have seen that we will mark the peroneal tendon in this way, and when we just do a percussion on the level of the uh, uh, peroneal nerve, you will have paresthesias on the lateral aspect of the leg. Now, McMurray's test is usually done in a supine position, and as far as the meniscus test is concerned, we do 3 tests. In the supine position, it is a McMurray's test, and we put our finger on the supine aspect and on the on the medial and the lateral aspect, and we flex and we rotate the knee, rotate the leg internal and external. If the patient has pain on the lateral joint line, it is suggestive of a lateral meniscal tear. If the patient has pain on the medial joint line, it is suggestive of a medial meniscus tear. So McMurray's test is done in a supine position. The second test is a Epley's test, and Epley's test is a prone meniscus test. It is done in 2 ways. So the first test is the Epley's distraction test, in which we pull the, so Epley's compression test, we push the foot down and then do the internal and external rotation phenomenon. So we push the leg down, do an internal and external rotation phenomenon, and this will lead to a very good compression phenomenon, internal and external compression phenomenon. And this is done for both lateral and medial meniscus. Then comes the Epley's distraction test. So we push the thigh with our hand, and then we pull the leg, and then we'll do the same internal and external rotation maneuver of the leg. And Eppler's distraction test is positive when both ACL and meniscus is torn. So if it is positive, then both ACL and lateral meniscus or ACL and medial meniscus is torn. Now the last test for meniscus is a Thessaly's test, and Thessaly's test is usually done in a standing position. So in the standing position, you hold both the hands of the patient and ask the patient to stand on one knee, hold the patient so that she does not fall down, and ask the patient to rotate the knee internally and externally. If the patient has got pain, it is sign of this is a very sensitive sign to see the meniscal injury. Thank you. So these are the basic tests that you perform as far as the knee examination is concerned. So we have made a small questionnaire, and you can just check this questionnaire to see whether you have any you have learned properly with this lecture or not. So we encourage you to attempt the questionnaire. Thank you. If you have any question, you can ask.